Today we get to discuss the anxiety disorders. Every class period based on one category or a category of disorders. The DSM has well over 300 disorders. We're just getting like a handful in here. Certainly more than an intro, and we're going to go more in depth than an intro, and certainly I'm going to expect more out of you than an intro. So of course in our field we want to determine at what point is what the person experiencing something that we need to consider making a diagnosis for. Knowing that everyone experiences anxiety at some point, either at some point throughout the day or some point throughout the month of the year, what have you. If anxiety is on a continuum, where do we draw the line and say, now we're going to diagnose it? What do you think we look for? Knowing that everyone experiences anxiety, we look at how much does what this person's experiencing negatively impact their regular everyday life. Does it impact their work? Does it impact their relationships? Does it impact their physical health? Is it starting to cause some severe medical complications? We look at all that, that's when we kind of go ahead and make a diagnosis. To an extent, anxiety is actually normal. That stress that we feel is actually helpful. How does that stress out, how does that help us? Stress generally is a motivator. It means it's telling us, look, you got to do something about this and get on it. What's a reasonable response to what's going on? We also want to be sure not to minimize someone's distress. Because if someone's distress is really starting to get in the way of regular everyday life, we've got treatments for that. When category of anxiety disorders comes up, there's usually a discussion of two different topics. One of them is fear, and the other one is anxiety. When we talk about fear, a reaction to immediate or perceived danger. I want to be sure that we know fear is normal and natural, and we need it to help us make good decisions to keep us safe. Fear, that is something that's going on right here, right now. That's going to be a little bit different than anxiety. Sometimes co-occur. This has to do with our concerns or worries about what might happen. So if we're anticipating a problem in the future, we might feel very unsettled about that. What if is very hopeful for some people. But for some people, what if is so heavy and their mind starts spinning and they start getting nervous. What if this happens? What if this happens? What if I accidentally say this? And what if this happens? And then this is going to happen. Some people in their minds kind of play that out all the time. How would it be if you were playing out these what if scenarios all the time? And I'm not saying the what if hopeful part. I'm saying the what if I drive through a big pothole and then my tire, you pull over like everyone else, and then what if I get hit when I'm trying to change my tire, and then what if this happens and I can't get home in time, and then what if I cause an accident? How might that feel? Whose mind is doing that all the time, and we would never know because we can't see everyone's thoughts. But how we present ourselves is sometimes different than what we feel like we're going on in our mind. Does what is going on in this person's mind negatively impact their regular everyday living? If it doesn't, not a disorder. All of us, we have such variance in our personality. How we think about the world, how we perceive things. Some people are just a little bit more on the anxious. That is just actually, if you study personality theory, some people are just really kind of chill and relaxed, and their brains don't necessarily go there. We want to make sure that we are not pathologizing normal variance in personality. We're looking at, does this person's set of symptoms fit a pattern? And if the pattern is there, is it interfering with the regular everyday life? Again, why are we diagnosing? To try and help. For the record, anxiety disorders are the most commonly diagnosed category of psychiatric conditions. People who have a diagnosable anxiety disorder have a much higher risk for cardiovascular disease, lower quality of life, they have more problems in employment, increase in medical costs. The things that people don't necessarily think of is research shows that people with anxiety disorders are more likely to experience what we call suicidal ideation. This is someone who is reporting thoughts of harming themselves. They are twice as likely to experience suicidal ideation compared to those without any type of psychiatric diagnosis. We'll talk about specific phobia first. I'm going to use this term a lot. Marked. It just means significant. A marked fear or anxiety of a specific object or situation called the phobic stimulus. Could be a situation or it could be a specific object. Criterion number 2, the phobic stimulus causes immediate fear or anxiety. Criterion number 3, the phobic stimulus is avoided or endured. Number 4, the fear or anxiety is out of proportion to the actual danger posed. In this case, the duration of symptoms is at least 6 months. And the last one causes soft impairment, social and or occupational functioning impairment. Your guys' responsibility is to read up on the specifiers. This is not this chronic, everyday, overwhelming anxiety. This is based on the situation. The response is kind of outside of what we would expect. She doesn't always act like that. It only surfaces if she's in the presence of a spider. If people talk about spiders, she's going to get nauseous. When you are looking up treatment, make sure you read about systematic desensitization, which is kind of the undoing of classically conditioned responses. In order for us to make a diagnosis of this, they have to be pretty intense. It takes a little clinical judgment there. You have to see how does this actually impact this person's regular everyday life. We all have fears, some of them rational, some of them irrational. If it doesn't create a really kind of drastic reaction, it's likely not a phobia. There is a gender disparity. For every 2 females diagnosed with a specific phobia, there is 1 male diagnosed. Could be maybe societal, could be that maybe females seek out treatment, therefore they're more likely to get diagnosed. Could be they're more exposed to these phobics. It could be anything. When we look at prevalence rate, a lifetime prevalence rate of about 13.8%. Questions, comments about specific phobia, which is social anxiety disorder. Previous to the DSM-5, this used to be called social phobia. Criteria number 1. So a marked fear or anxiety regarding social situations where scrutiny is possible. Criteria number 2, intense fear of humiliating or embarrassing oneself or being negatively evaluated. Criteria number 3, the phobic stimulus is avoided or endured with fear or anxiety. Number 5, duration of at least 6 months. Lastly, causes soft impairment. It's what we call episodic. It only happens and there's a beginning, there's an end, and then the person's fine in between. There's no gender disparity. The prevalence rate, thank you, is about 8%. Panic attacks are short-lived. They start, they end, they usually peak within about 10 minutes, and they are real, physical, measurable symptoms. The basis for them seems to be due to this flood of anxiety that is surfacing as physical symptoms. Having a panic attack, or even having multiple panic attacks, does not automatically trigger a diagnosis of panic disorder. Number 1, at least 1 panic attack and 1 or more months of worry about future panic attacks. And then number 3 would be and or 1 or more months of changes in behavior, not a well-adjusted. We usually see this in the form of avoidance, by the way. Number 4 is required. There is no known trigger. The panic attacks are unexpected. This is new to the DSM-5, and it wasn't super well received. Coming from the biological perspective, does our sympathetic nervous system sometimes just fire when maybe it didn't really need to at that time? And if that sympathetic nervous system was activated really, really intensely, even though it didn't even need to be, could that explain a panic attack? Some people, just when we look at the normal variation, the way some of us are wired, we're a little bit more anxious than others. Just because someone knows their trigger, it doesn't mean they're not really struggling. And my behavior is changing so much, and I'm avoiding so much, it's negatively impacting my regular everyday life. I may not meet the criteria for panic disorder, but I'm definitely still struggling. In the DSM-5, we have categories where if it's very clear that someone is struggling with a mental health issue, in this case with panic attacks, but they don't neatly meet some of the criteria for the major disorders, it's called the unspecified category. That diagnosis would be enough to trigger treatment. Prevalence is about just over 3%. So with the DSM-5, agoraphobia is its own diagnosis. Prior to the DSM-5, if someone had panic disorder, you had to say with or without agoraphobia. That was a specifier. A specifier is just a little bit more information. Now, agoraphobia is its own disorder. Criteria number 1, marked fear or anxiety of at least 2 of these. Open spaces, public transportation, enclosed spaces or small spaces, standing in a line, being in a crowd. Number 2, avoidance or fear of these situations, the ones listed above, because escape might be difficult or help unavailable if something happens. Criteria number 3, so the situation is endured with intense fear, or is avoided altogether, or requires the presence of a companion. This is the next one. The fear is out of proportion to the actual danger posed. Causes soft impairment. The fear of being in public places, or in wide open spaces, or in a big crowd, or in a line, or even in small spaces. And the reason they're so fearful of those is because if something happens, they're afraid that no one will help them. Oftentimes it's panic attacks. So that fear, anxiety, is so intense that they stop going to those places. Or if they go, they're with someone and they're enduring it with intense fear or anxiety. Often to the point where they do not leave their house. So we definitely want to intervene and provide treatment before it gets to that point. It is not a common or typical reaction. We all have anxiety, but it doesn't create such behavior change or such maladaptive behaviors that we only just stay in our home. Nope, that's agoraphobia. We good? All right, prevalence rate of agoraphobia, 1.7. Interesting too, this is not in your textbook, but I think it's really important to mention. If they meet the criteria for agoraphobia, they have a less than 10% chance of working through this on their own. All right, so are we ready to go on to generalized anxiety disorder? All right, let's do it. Generalized anxiety disorder. Criterion number 1, excessive anxiety and worry about many events or activities, and they can't let it go. So excessive anxiety and worry about many events or activities, and they can't let it go. So when we talk about what are these events or activities, it's this chronic, heavy cloud of worry about many different things that follows the person all the time, everywhere. There seems to be no reprieve, even though they want to. They can't just kind of let it go. Okay, so might we see impairments in sleep? Absolutely we do. It's not a requirement, but reasonable. You can't sleep. Your concentration is pretty terrible. You're quick to become frustrated or angry, so you're very irritable. You feel sick a lot. Headaches, stomach aches. Can't sleep right. Your mood is impacted. Your problem-solving ability, your ability to learn, everything seems to be impacted. It's exhausting. And all you want to do is sleep, but you can't sleep. That was all criteria number 1, by the way. Criteria number 2, difficulty in controlling the worry. Criteria number 3 is they need at least 3 symptoms, including sleep disturbance, restlessness, feeling edgy or irritable, difficulty concentrating, muscle tension, so like a lot of aches and pains, fatigue. But there's a specific thing about fatigue. Think about the amount of gas you have in your car. You have a certain amount of gas. When someone's experiencing fatigue, they run out of gas so quick. Stamina is not what we would expect it to be. Far quicker than other people their age in their common situation. Okay, so they need at least 3 of those. There's more. Duration is at least 6 months. And certainly soft impairment is your last criterion there. You know, usually by the time that someone seeks out treatment, they can say, well, when did this start? And they'll say, oh my God, it's been like about a year. Sometimes the assumption is some kind of medical issue, ruling out mono, ruling out anemia, let's check your iron, oh, maybe you have hypothyroidism, so they look at all these things, and usually once they rule it, and all of that should be ruled out before someone gets a diagnosis of generalized anxiety disorder. However, I have that unspecified category. I could say anxiety disorder unspecified. Once 6 months hits, then I can change it to general. Okay. Make sense? Yeah. What we don't want them to say, well, thanks for coming in, and in 4 more months, come back, and then we can get you treatment. You have to look for some kind of a change in behavior, though. Like if they always hated their job and they always went for a paycheck, then we wouldn't count it. But if they used to really thrive and they were getting all these promotions and now they've kind of come to a screeching halt and they can barely get themselves to put in the 40 hours, now we see there's something different. And all that takes clinical judgment. Usually if you look hard enough and ask the right questions, the soft impairment is often there. Not always.